Oh, say, can you see by the dawn's early light what so proudly we hailed at the twilight's last gleaming, whose broad stripes and bright stars through the perilous fight o'er the ramparts we watched were so gallantly streaming, and the rocket's red glare, the bombs bursting in air, gave proof through the night that our flag was still there. Oh, say does that star-spangled banner yet wave o'er the land of the free and the home of the brave?
Hi, my name is Sue Gu, and I'm here to talk to you about classifications of pulmonary hypertension. The WHO classifies pulmonary hypertension into 5 distinct categories, grouped by similarities in pathophysiologic mechanism, hemodynamic characteristics, and the treatments. WHO Group 1 pulmonary hypertension, or pulmonary arterial hypertension, is due to pulmonary hypertension from unknown or idiopathic causes, genetic pulmonary hypertension or hereditary causes, drug and toxin exposures, and diseases associated with pulmonary hypertension like connective tissue disease or autoimmune diseases like scleroderma, lupus, and Sjogren's disease, HIV, portal hypertension or chronic liver disease, and congenital heart disease. There are many FDA-approved treatments for this particular type of pulmonary hypertension. WHO Group 2 pulmonary hypertension is due to left heart disease or from elevated pressures on the left side of the heart, either due to stiffening of the heart muscles or inability of the heart muscles on the left side to pump blood effectively. This is often associated with diseases like coronary artery disease, high blood pressure, aging, heart valve disease, or heart attacks that may have damaged the heart muscles. Therapy is focused on treating the underlying left heart disease. Group 3 pulmonary hypertension is due to chronic lung disease, such as COPD, interstitial lung disease, or any other lung disease causing chronically low blood oxygen levels, or obstructive sleep apnea, which causes low oxygen levels at night. Therapies are focused on treating the underlying lung disease and correcting the problems with the low oxygen, such as wearing a CPAP or wearing oxygen. Group 4 pulmonary hypertension is chronic thromboembolic pulmonary hypertension, which is pulmonary hypertension caused by chronic blood clots. Treatment is focused on surgically removing the old clots or opening up the arteries where blockages may exist. Medications like anticoagulation that prevent the formation of new clots, and certain oral medications that are approved for this particular type of pulmonary hypertension. Group 5 pulmonary hypertension is pulmonary hypertension resulting from unclear or multiple different mechanisms. The associated diseases include sarcoidosis, blood cell diseases like sickle cell anemia or chronic hemolytic anemia, and certain bone marrow disorders, a history of spleen removal, and metabolic diseases like Gaucher's disease and thyroid disease. The therapies for this type of pulmonary hypertension are focused on treating the underlying disease.
Hi, everybody. My name is Dr. Peter Hountras, and I'm one of the pulmonary hypertension physicians at the University of Colorado Hospital. It's great to be with you guys today, and I have the pleasure of discussing with you guys the workup and diagnosis part of pulmonary hypertension. And When we see patients in clinic that are coming to see us out of concern for pulmonary hypertension, the first step in the diagnosis is usually for the patients to have what's called an echocardiogram or an ultrasound of the heart. That's done either here at our hospital or at another hospital with your doctor. And essentially they put jelly on your chest and put a probe in several different positions to try and give us some very good pictures and allow us to make some measurements as far as the function and the pressure of what's going on in your heart. And if the pressures in the blood vessels in the lungs and the right side of the heart look elevated and abnormal, that is when we're concerned about a diagnosis of pulmonary hypertension being there. And so once we see that, we meet with you in clinic and spend a lot of time trying to get to know you, hear your story about who you are and the things that have kind of happened in your life, asking some very specific questions about experiences, exposures that could help us to understand what may be causing your pulmonary hypertension. And the reason is because there's technically 5 different categories of pulmonary hypertension, none of which are mutually exclusive, meaning you could end up in more than one. And so that could be anything from chronic blood clots to underlying lung disease like COPD or emphysema, scarring of the lungs, or even sleep apnea. Could be left-sided heart disease caused from heart failure or valve issues, or it could be this grab bag that we think of as pulmonary arterial hypertension, where people get it because of other family members, because of their liver, because of drug or toxins, or even just because we don't have an understanding at all as to why they got it, or what we call idiopathic pulmonary arterial hypertension. And so we will ask those questions to try and understand where to go, and then we'll initiate a general workup to be able to rule out a lot of those causes. And because as we're trying to figure out treatment, it's important to know what types of pulmonary hypertension you may have, because it will guide us in how we can best take care of you. And so that will include a good amount of lab draws and looking at blood to take a look at your kidneys, your liver, your thyroid, to make sure that that HIV is not a player in this. We'll take a look and send for autoimmune labs, ruling out things like rheumatoid arthritis or lupus or scleroderma. We'll also make sure to look at labs to take a look at your heart and the stretch and the effect on your heart. And then we'll send off for specific imaging studies to look and rule out chronic blood clots or something called CTEPH, chronic thromboembolic pulmonary hypertension. We'll then ask you to have pulmonary function tests done, which is essentially where you'll sit in a big glass phone booth type of a machine, and you'll breathe in and out, which will allow us to understand how strong your lungs are, what the volumes look like, and if there's any evidence of underlying lung damage. If you have risk factors at all for sleep apnea because you snore at night, or somebody said that when you go to sleep, you stop breathing, we will advise you to get what's called a sleep study. Usually that means you'll go sleep at a center around Denver, and they will put some monitors on you and watch your heart rate and your breathing and your oxygen. And then it advises if there's any evidence that you stop breathing while you sleep or have a diagnosis of sleep apnea. And then lastly, as we get all of that information back, we will proceed to the confirming, essentially, test, and that is a right heart catheterization. And essentially what that allows us to do is we bring you into the hospital for a procedure. It's an outpatient procedure, meaning you will go home the same day. We give you a little bit of medication to make you sleepy. And then we take a catheter to go in, usually through the neck in one of your large veins, and take that catheter down into your heart. And at the end of that catheter is a probe that allows us to measure the pressures from directly inside your heart and the vessels in your lungs, and potentially even doing other procedures to look if we think that there are chronic blood clots there. And then taking those measurements to essentially understand from inside your heart what the pressures are, which will help us confirm if there is a diagnosis of pulmonary hypertension or not. And then based on those numbers and based on our previous described workup as far as the diagnosis, at that point, we will be able to discuss treatment and what happens.
Well, thanks very much for joining us today. I'll provide a brief overview of current treatments and a snapshot of what's being explored in clinical trials. There are currently 14 therapies approved by the Food and Drug Administration for the treatment of pulmonary arterial hypertension. They've been approved over the course of the last 2 to 3 decades as a result of a large amount of clinical research in the field. For many, what this has meant is that the disease has gone from being highly lethal to being somewhat to largely controllable. It's more of a treatable and manageable chronic illness now than it was 2 to 3 decades ago. The prognosis has improved substantially. As of the mid-1980s, when an NIH registry was conducted on pulmonary hypertension, or what was then called primary pulmonary hypertension, the median or average survival was about 2.8 years from the date of diagnosis. Now the survival is much better than that, the median survival. As of 2010, 2012 or so, when the REVEAL registry was completed, the median survival had improved to about 7 years. It's better than that now. We don't know exactly where it stands, but I think it's probably substantially better as a result of the treatments that I'm going to tell you about. So currently available therapies approach 3 different treatment pathways, and those include the prostacyclin pathway, the endothelin receptor antagonist pathway, and the phosphodiesterase inhibitor pathway, or phosphodiesterase pathway. Some call that the nitric oxide pathway. General treatment measures include things like supplemental oxygen to maintain saturations of 90% or better at all times, diuretics to maintain a euvolemic state, vaccinations to prevent avoidable diseases, and that's become increasingly important recently, and I'll address that briefly in a moment. Avoidance of pregnancy, which can place a large cardiovascular strain on a pregnant female. Diet in terms of restricting sodium intake and optimizing weight. Exercise and cardiopulmonary rehab. Cardiopulmonary rehab has really become a cornerstone of treatment in the last 5 to 10 years or so. And then treatment of obstructive sleep apnea if that happens to be present. So I'll come back to vaccinations for a moment because it's a particularly timely topic. We have always recommended influenza vaccination in the absence of an allergy or some other contraindication. Influenza is poorly tolerated by patients with severe pulmonary hypertension, and it's largely preventable. We've also recommended pneumococcal pneumonia vaccination for many years. And now, of course, the vaccination of greatest interest is with respect to COVID-19. And COVID-19 is potentially highly lethal to a patient with significant pulmonary hypertension. The vaccines are generally highly effective and quite safe and well tolerated. The risk-benefit ratio, which is something we've always looked at in our treatments and for vaccinations, for the COVID vaccines is highly favorable. The COVID vaccines can prevent severe disease and hospitalization and death. And of course, avoiding those things are highly important to our patients. So we strongly recommend vaccination unless there's some strong contraindication to doing so. Then as we complete the evaluation of patients with pulmonary hypertension, and I know that there's been another talk on this already, we tend to assess for vasoreactivity. And if that's found to be present at the time of right heart catheterization, we often prescribe a calcium channel antagonist as a first step in therapy. Unfortunately, only about 10 to 15% or so of patients are truly vasoreactive and therefore candidates for treatment with calcium channel antagonist. It's still important to identify this small group of patients because those treatments are quite effective in that limited subset, and they're relatively inexpensive and well tolerated. However, for the vast majority of folks, as I've mentioned, people are not acutely vasoreactive and therefore won't tend to respond favorably to calcium channel antagonist, and they require one of our other therapeutic options. I mentioned earlier that there are 14 FDA-approved therapies for pulmonary hypertension now. They fall into 3 therapeutic classes, as I mentioned, the prostacyclins, the endothelin receptor antagonist, and the phosphodiesterase inhibitors, or there's one stimulator of soluble guanylate cyclase that also falls into that nitric oxide pathway. So the three endothelin receptor antagonists that are available include bosentan, ambrisentan, and macitentan. Those drugs all work by blocking a small peptide hormone known as endothelin and prevent vasoconstriction and cellular proliferation. The second class of therapeutic agents acts on the nitric oxide pathway, and they include two phosphodiesterase inhibitors, sildenafil and tadalafil, and one stimulator of soluble guanylate cyclase, riociguat. Those agents are generally well tolerated. I should mention the side effects of the endothelin receptor antagonist can include things like nasal stuffiness, headache, lower blood pressure, and fluid retention. Bosentan can be associated with potential liver toxicity, and all three of the endothelin receptor antagonists are considered teratogenic or can cause birth defects, and therefore are absolutely contraindicated in pregnancy. The phosphodiesterase inhibitors are generally well tolerated. They can cause headache, lower blood pressure, and sometimes some dyspepsia or gastrointestinal upset. The stimulator of soluble guanylate cyclase, riociguat, generally well tolerated again, but can also cause some systemic hypotension, and it's generally best to up-titrate the dose of the drug cautiously and monitor the blood pressure while doing so. And then finally, the prostacyclins can be administered intravenously, subcutaneously, by inhalation or orally. And they include epoprostenol, treprostinil, and then the prostacyclin-like agents include selexipag, and another oral preparation of a prostacyclin is the oral preparation of treprostinil. So those agents are all effective and generally fairly well tolerated if their dose is up-titrated slowly. We found that subcutaneously administered treprostinil is a bit limited by site pain and discomfort at the infusion site, and therefore we tend to reserve that agent for patients that need a parenteral prostacyclin but cannot have an IV catheter in place for one reason or another. The oral prostacyclin preparations may not be as effective as parenteral agents, but are an alternative. They can be associated with gastrointestinal upset and need to be up-titrated cautiously. The most effective therapies that we have, medical therapies, are the parenteral or intravenous prostacyclins, and they include intravenous epoprostenol, treprostinil, the various preparations available these days. And again, they require cautious up-titration in a center that's familiar with caring for patients with pulmonary hypertension. I would recommend that all patients receiving medical therapy for pulmonary hypertension be seen in a center of specialized expertise. Those centers tend to be accredited by the Pulmonary Hypertension Association. Finally, I'm going to mention some clinical trials. We have a number of clinical trials ongoing these days. Some of them explore novel therapeutic agents with antiproliferative or immunomodulatory activities. And then other clinical trials involve new ways of delivering therapies that have previously been explored, or combinations of therapies that have previously been explored. Finally, I'll add that if patients fail all available medical therapies, lung transplantation may be an option in a selected group of patients who meet the criteria for transplant. And with that, I'll end, and I'm always happy to take questions, perhaps not in today's format, but if you'd like to contact us, I'm happy to address any questions that you might have. Thank you for your support of our pulmonary hypertension program. Enjoy the opportunity to work with all of you. Thanks.
Hello, my name is Todd Bull. I am a pulmonary and critical care physician at the University of Colorado and director of our pulmonary vascular disease program and our Center for Lungs and Breathing lungs and breathing at the university. And I'm very happy to have you here participating in our PH in the Park program, our fundraiser, or one of our major fundraisers for the pulmonary hypertension program within pulmonary vascular disease. This particular fundraiser has been going on for a number of years now, and it's a great opportunity for us to all get together. Obviously, the pandemic has made that somewhat more difficult of late, but we are having these online versions as well as the face-to-face opportunity for those who want to exercise on this day. And so this is our educational session. I have been tasked with discussing the disease state of chronic thromboembolic pulmonary hypertension. And so likely, as you've heard from others in this video educational series, there are 5 groups in which we divide pulmonary hypertension. Pulmonary hypertension really being a hemodynamic definition of high pressures in the pulmonary vascular bed, and 5 separate groups, the 5 WHO groups of pulmonary hypertension, and CTEPH, or chronic thromboembolic pulmonary hypertension, is within group number 4, so as a designation in and of itself. And essentially what CTEPH is are clots that form within the pulmonary vascular bed, or more likely embolize to the pulmonary vascular bed, and then don't resolve. And by blocking the pulmonary arteries, they make it more difficult for blood to pass through the pulmonary vasculature, and like any, so you can think of any sort of basic physics, if you will. If you occlude or block a pipe, it takes essentially higher pressures to push the blood through. The response is higher pressures, and that's essentially what's happening in CTEPH, or chronic thromboembolic PH. Now, blood clots, pulmonary emboli, are in fact very, very common entities. It's estimated that somewhere between 800,000 and 1 million new cases of venous thromboemboli occur every year in the United States alone. That's probably a significant underestimate. Those are just the ones that we diagnose. And these are essentially anomalies of the pulmonary vascular, or of the clotting cascade. They can be induced, caused by a variety of things, such as trauma. For example, in the COVID pandemic, it's our suspicion that COVID is increasing the risk of pulmonary emboli or blood clots. Or they can come spontaneously. Some people have a higher propensity to clot and make blood clots. Those blood clots frequently come from the lower extremities, can come from the upper extremities. Embolies pass through the heart and then lodge in the pulmonary arteries. Again, this is a fairly common occurrence, can be life-threatening, though most patients do survive the acute clot. In about 96% of the time, those blood clots will resolve. That is, we put you on blood thinners because we realize you had a blood clot, and your body actually breaks the blood clot down. The blood thinners really prevent more clots from occurring, and your body does a very good job of resolving the blood clot. And we sort of intuitively know this, right? We are making blood clots all the time. Our bloods are clotting. If you cut yourself, your blood clots to stop the bleeding, but your body then dissolves the clot. That's sort of the natural process of thrombolysis or fibrinolysis. But somewhere between 1% to 5% of the time, someone has a blood clot and that clot does not resolve. And we don't really understand the reason for this. This is an area certainly of active research, trying to piece out what it is about certain individuals that their clots don't resolve in their pulmonary arteries. But when that does occur, and then enough of those clots build up, that again can now block those pulmonary arteries, so that those tubes, the arteries through which our right heart ejects blood to go to the lungs, can be obstructed. When they're obstructed, the pressure rises. If the pressure rises enough, that is enough of an obstruction, it puts a strain on the right side of the heart, and you develop right heart failure. Now, this is a really important cause of pulmonary hypertension from the standpoint is that we have some very specific treatments for it, and it's sort of one of the forms of pulmonary hypertension that we talk about curing, if you will. That is, we can bring the PA pressures, the pulmonary artery pressures, back to normal if we can make this diagnosis and if other things align in terms of where those clots are. And so whenever we see a new patient with pulmonary hypertension, as part of our initial evaluation, we are trying to categorize in which WHO group does this patient reside. And if it's in group 4, then we look at some very specific treatments that I'll touch on here in a moment. So what are the initial symptoms of this? It's very typical of other forms of pulmonary hypertension, and they're non-specific, which can make this difficult to diagnose. It's generally with decreased energy, worsening shortness of breath. As the pulmonary hypertension gets more severe, then the patients can develop evidence of right heart failure with lower extremity edema, lightheadedness, fainting, near fainting, things along those lines. So how do we screen for this? So we first hear about those symptoms, or one of your other providers, physicians, hears about those symptoms. Frequently, an echo is the study that kind of points us in the direction of pulmonary hypertension. And then, as part of the evaluation, as we're taking history, looking at other labs, one of the other studies that we essentially almost always get is something called a VQ scan, or a ventilation perfusion scan. And this is an imaging study, non-invasive study, looking to see if there's obstruction in the pulmonary arterial bed. We consider that a better screening study than CAT scan, which is what's usually used to find pulmonary emboli, though honestly CAT scan can be quite useful as well and can help us make the diagnosis. And if those entities are positive, and again, kind of depending on what else we're seeing in the individual, when we move to right heart cath, we'll do a rather different kind of right heart cath. We'll do a typical one where we measure the pressures, but we'll also do what's called a PA-gram, pulmonary arteriogram, where we shoot dye specifically into the arteries that we're interested in to try to localize exactly where that clot is and how much clot is there. And again, this is now clot that has, by definition, been there for more than 3 months. So we want to be on anticoagulation for at least 3 months. We treat. If that clot resides there, we start worrying that this could be chronic thromboembolic pulmonary hypertension. And then, if we continue to see this, then we'll kind of launch into further evaluation. And as part of that evaluation, essentially what we're trying to decide is best therapies, and of which we really have now 3 modalities. And I'll say 4. We still it's very, very important that you stay on blood thinners once we've made the diagnosis of chronic thromboembolic pulmonary hypertension, because we don't want any more clot to get up there. But it's also important to understand that now, once that clot becomes chronic, the blood thinners are not going to help resolve it. And in essence, what's happened is the endothelial cells have covered the blood clot. Your body can't get to it anymore. The endothelial cells are cells that line all of our pulmonary arteries, or all of our arteries, or vasculature for that matter, covered it, and they can't get to it. So now we're coming back to treatment. So now we've got this kind of chronic clot that your body can't get at, can't resolve. We still want you on blood thinners. That's a very important aspect of the treatment to make sure no more clots occur. And then we essentially are looking at medical therapy, which we have one FDA-approved drug called Adempas, or Riosequat, currently approved for the treatment of chronic thromboembolic pulmonary hypertension. That is to try to lower the pressures. It was approved in a sentinel study in 2014. We've been using it since that time. It works essentially through the nitric oxide pathway and relaxes the pulmonary arteries to let blood flow more easily through them, but doesn't do anything particularly to the clot. It's just trying to lower the pressures, take the strain off your right heart. The more definitive treatments, one of the second treatments, but probably one of the most important modalities, and why this disease state is very different than the other forms of PH, is a surgery to remove the clot. And this specific surgery is referred to as a pulmonary thromboendarterectomy. It's kind of a mouthful, but PTE, pulmonary thromboendarterectomy. And this is essentially again a huge surgery. Usually 6 to 8 hours of surgical time. It involves stopping the heart for essentially 20-minute increments, so complete heart standstill, and allowing the surgeon a bloodless field to then dissect down into the pulmonary arteries and then remove the clot. And do this on both sides, both pulmonary arteries, and again, usually it's done in 2 to 3 what we call circ arrest periods, of where the heart is completely stopped, held, and then no blood flow for a 20-minute period of time. And then we used ECMO and then deep cooling to protect the brain. ECMO, extracorporeal membrane oxygenation, to help with circulation and oxygenation of the blood. So big surgery, but in the right individual, this is essentially, if you will, curative. I'm going to use that term loosely because it's not that the pulmonary vascular bed is totally normal after that, and you still need to be on blood thinners, but we can lower the pressures to normal. And this is, in fact, something we're offering at the university now. We started this program, the surgical program, a couple of years ago now, and have had great success with this to date. Been a very exciting new chapter for us at the University of Colorado, and really are excited to be able to offer that to the patients that we take care of, and certainly, again, always screen for this. The third modality of treatment for CTEPH in particular, chronic thromboembolic PH, is one that we're getting ready to offer at the university, and this is called balloon pulmonary angioplasty. It involves another catheter-based approach where we pass a wire and then a balloon into where the clot is, expand the balloon to kind of, if you will, smash the clot against the pulmonary vascular bed. It's a technology that's been used in coronary disease quite a bit. You maybe know a family member or a friend that's undergone this for blockages in the heart vessels, the coronary arteries, used in other parts of the vasculature, veins and arteries to open up stenoses, blockages, etc., and can now be applied in the pulmonary arteries. A relatively, again, new technology or move into that, really being more widely used the last couple of years, and we hope to start performing those procedures here in the next 6 months or so at the university. So another modality we can use. So to summarize, then, chronic thromboembolic pulmonary hypertension is one of the important types of PH to recognize. It is WHO group 4 if you want to categorize it. It is a chronic clot that becomes covered by endothelial cells, and so your body can no longer dissolve the clot. It raises pressures by blocking the pulmonary arteries, and we have some very effective treatment measurements that run from surgical, moving towards the somewhat less invasive balloon angioplasty, and then the medical therapy, currently with one approved drug, Adempas. We are studying now multiple other medications to see if they're efficacious in this disease state. That is really a very brief summary. These are obviously topics we could talk about for much more time, but again, I want to thank you for attending our conference, either virtually or in person, listening to our educational opportunities, and again, it's a pleasure to and an honor to be able to participate in this fundraiser, but all more importantly, with our really excellent group of nurses, clinicians, volunteers, and then also to work with the patients like yourself to really try to improve how we're able to care for patients in this process. With that, I will stop and thank you very much.
Welcome, everyone. I'm Dunbar Ivy. I'm Chief of Pediatric Cardiology at Children's Hospital Colorado and the University of Colorado. I'm excited to give you this presentation as part of our education for the 12th PH in the Park run. I am a pediatric cardiologist and run the pediatric program. And so I'd like to tell you a little bit about pediatric pulmonary hypertension and the similarities and differences between children with pulmonary hypertension and adults with pulmonary hypertension. So to start off, the definition, how we define pulmonary hypertension is the same in children and adults. And we can tell there's pulmonary hypertension by a heart ultrasound or echocardiogram, but the definitive diagnosis is by cardiac catheterization. And so those numbers that we use are the same in adults and children. So it is needed to have a heart catheterization to confirm pulmonary hypertension. And so we say that you need a mean pulmonary artery pressure greater than 20 millimeters of mercury, and also a resistance or the pressure drop between the pulmonary artery and the left side of the heart divided by the flow of greater than 3 Wood units. Now, likewise, there are similarities in how we classify pulmonary hypertension in children. And for the last several World Symposium meetings, we've increased the number of pediatric diagnoses in this classification. And so those 5 basic groups that you probably have heard of are very similar between children and adults. Now, most of the pulmonary hypertension that we see is so-called group 1 pulmonary arterial hypertension. And the most common things that we see are idiopathic pulmonary arterial hypertension, also called unexplained, and a very long time ago called primary. But this means we look for all causes of pulmonary hypertension. And if we can't find one, then we call it idiopathic. Likewise, compared to adults, we have genetic causes, and the genes that cause pulmonary hypertension are slightly different than adult, but mostly the same. We see this BMPR2 mutation as the most common, but a newer gene that's been really evaluated in the last couple of years called TBX4 is sort of next on the list. So we do have now over 20 genes that we can evaluate for pulmonary hypertension. And so we certainly look for those in children also. And then congenital heart disease, or different holes in the hearts or different malformations, is also one of the most common in children. And luckily these days, almost all of these children can have surgery and not have pulmonary hypertension afterwards, but there's still some who show up late and can't have surgery, or some who develop pulmonary hypertension after surgery. Now, it's important to note that we see pretty much all the same causes, but the frequency or the percent of children with those abnormalities is much different. So for example, it's rare that we would see clots in the lung or thromboembolic pulmonary hypertension, or something called scleroderma that as an adult they would see much more common. Also much more common that we would see pulmonary hypertension at birth, right after birth, called persistent pulmonary hypertension of the newborn. Now, when we look at these babies with pulmonary hypertension, frequently their lungs have not developed normally, and this includes the airways as well as the blood vessels. And some of the children that were born very early can go on to develop what's called bronchopulmonary dysplasia, or chronic lung disease of infancy. So we see a wide variety of things that can cause pulmonary hypertension. And our first goal is to try to define the cause of pulmonary hypertension and treat it as we can before adding therapies. Now, let's talk a little bit about therapies. So I'm sure you've heard from the other presentations that there are over 11 medications that have been approved for adults with pulmonary hypertension. But so far in the United States, only one therapy is approved. And so one of our goals as pediatric pulmonary hypertension doctors is to learn as much as we can about these drugs and to try to find ways to get them approved. Now, sometimes we use these drugs so-called off-label. That is, they're approved for adults, but we use them in children, but we only use drugs that are FDA approved for adults. So that's a big hurdle for us dealing with children, is to try to understand as much as we can about drugs for children and how to get them approved now and in the future. But I think using these drugs, we've had, a definite improvement in survival. And I look forward to the next 4 to 5 years where we work with the agencies to develop these drugs and hopefully get them approved for children. So have a wonderful day today, and thank you for listening to this presentation.